So it's a bit the criteria and that is a clinical criterion, obviously, what have the patients received in the metastatic hormone-sensitive state. So that's an important criteria. Then obviously there's always criteria from the patient itself, so himself. So in that sense, is it a fit patient, a patient who is fit for chemotherapy? Is it a patient who's not fit for chemotherapy? I think that is one, I guess, quite important thing to really try to evaluate, and especially in elderly patients, it's very helpful to do a geriatric assessment to see which patients can tolerate really chemotherapy. And then obviously we have now these kind of more like precision medicine markers. So in that sense, so we have, at least until now, we have always thought that, okay, BRCA mutations, that are the patients who we want to give a BARP inhibitor. And we're going to discuss that later now. Maybe that has been a bit, discussed at this ASCO GU. If that's really only these patients or not. So I still think that we should go for the biomarker selected patients, but there was, as you maybe have seen, some discussion if we now should, after the proper data, after the TALA-Pro data, should we give it to an unselected population? And then we have obviously lutetium PSMA that is also given with a biomarker PSMA positivity. So that's a bit more complex, but we have a biomarker there as well. So our nuclear medicine specialists tell us if someone is suitable for this treatment, lutetium PSMA, or not. And then radium was always actually only for the patients who were symptomatic, so had pain, and have bone predominant disease. So this is another drug that is sometimes difficult to find the best place for, but is also in a really selected patient population.